I'm especially grateful to the organizers to have invited me to share with you some of the main findings about the problem we face in heroin maintenance treatment, that is dual diagnosis patients. And what I try to do is to have a short word about psychiatric comorbidity and opiate dependence in general, in methadone maintenance treatment, and then, of course, comorbidity at entry to heroin-assisted treatment, outcomes of psychiatric comorbidity in heroin-assisted treatment, and comparing these outcomes with those in methadone maintenance. And final summary will try to get you the main messages. Psychiatric comorbidity in opiate dependence can be studied from this meta-analysis of 16 studies where you can see that minimal one disorder is found in a large range from almost 50% to almost 100% of patients which have been looked at. And the priorities are with personality disorders, then affective disorders, then anxiety disorders, and very low rate of schizophrenic disorders. In methadone maintenance treatment, there are many data available. I just want to show you one of the classical studies. And you found down here one or more symptoms of psychiatric comorbidity in this large study. Lifetime, about 2/3, and last 30 days, more than 1/3 of patients involved. Well, there we go. Now I would like to go back. Retention in methadone maintenance treatment traditionally is considered to be poor if psychiatric symptomatology is present. McClellan, Joe, and others are the classical studies here. But in contrast to these traditional findings is a very recent one in Italy by Maremani and other researchers who found that patients with a DSM-4 axis 1 comorbidity have better retention as compared to non-comorbid patients, highly significant. It's not quite clear how this came about. It may have a connection with the high quality of the PISA services. Now, psychiatric comorbidity at entry to heroin-assisted treatment. We have touch data here in the study already mentioned by Wim van den Brink. Blanken have found that in a range of criteria about psychiatric disorders, we can see the sum score of symptom checklist is over 70% lifetime number of residential treatments, 0.4, ever attempted suicide, 28%, and so on and so forth. So a pretty high prevalence of comorbidity at entry to heroin substitution treatment. Swiss data show a similar picture. We have at least one disorder in 2/3 in lifetime and over 1/3 in the last months, with some interesting differences between female and male patients. The frequency of prevalence goes from affective disorders to anxiety disorders, eating disorders, schizophrenic disorders, and somatoform disorders. And it's very interesting to see that, for instance, affective disorders against traditional beliefs are higher in male participants than in the female ones. This was for axis 1 comorbidity. In axis 2 comorbidity, we find prevalence rates for personality disorders with these subtypes. And again, high rates of any one personality disorder are higher in females as compared to men. And overall, at least one axis 1 or axis 2 disorders has been found in 86% of patients entering heroin-assisted treatment. And also, it was interesting to see that the more comorbidity, the less cocaine use at entry. But on the other side, the more comorbidity, the higher the diazepam use and the cannabis use. This also is quite interesting to note. Could be interpreted as support for the self-medication hypothesis. Over the years, from 2000 to 2011, the frequency of psychiatric comorbidity was not changing a lot. You have here the frequencies for affective disorders, for personality disorders, and for other disorders. Now, outcome of psychiatric comorbidity in this kind of treatment. I have used for this presentation studies from Switzerland, Netherlands, Germany, Spain, and Canada. The assessment of comorbidity in these studies was not the same. So the comparability of the findings may be a little bit different. Also, the duration of follow-up is quite different. The outcome measures, again, are very different. Comparison groups, always methadone maintenance. In the Swiss cohort study, we had no comparison group, but there was one sub-study in Geneva by Perneter and co-workers. They used comparison with a waiting list design. You didn't find any comparison with placebo. This seems ethically not to be acceptable in this case, in view of the high mortality and morbidity risks of untreated heroin dependence. What is the course after starting heroin-assisted treatment? The first data over 18 months show very clearly that there is a sharp and continuous decline in severe forms of depressive disorder, anxiety disorder, and aggressive behavior. Whereas at the other side, you found an increase in mild depression, anxiety, and aggressive behavior, which means that they don't disappear, but there is an important improvement in these disorders. An ongoing analysis of monitoring data of the Swiss findings covering 2,242 patients over 12 years shows a provisional outcome that reduced hostility is found, while persistent dysthymia and depression is also found, and improved depression and social phobia on the other side. This is difficult to interpret in view of the high rate of missing data. This is not published stuff yet. Now the final part of it, comparing heroin-assisted treatment and methadone maintenance treatment for psychiatric comorbidity. The Dutch data, one part of it is that if you looked at patients with prescribed psychiatric medication or without, you see that treatment response rates in patients with psychiatric medication is lower than in patients without comorbidity. And in the methadone group, you cannot find a difference. Now, this could be discussed. The German data are also available, and this is a complex design. I don't go into the details here. They compared not only heroin-prescribed treatment with methadone treatment, oral methadone treatment, but they also compared special education going along with medication and usual supportive care. Now, what about treatment retention in the German data? If you have at least one disorder, you can see in the completers no difference. Dropouts, no big difference either. So there is not an enormous difference in odds ratios, when you look at differences in the treatment approach. Also in the German data, if you look at CD diagnosis, you can see that only in the case of neurotic, stress-related, and somatoform disorders, you have a significant difference between heroin-assisted treatment and methadone maintenance treatment. There is no significant difference for schizophrenia, affective disorders, and behavioral syndromes. Now, to look at Spanish data in the Andalusian trial, you find a significant difference in psychological status and adjustment between heroin-assisted treatment at 9 months and methadone maintenance at 9 months. And in the Canadian data, also we found a significant difference in mental health status and social integration between the two treatment approaches. And this is just to show you which studies and which references have been included into this analysis and where significant findings could be documented. In the Bernecker study, there was a significance, no significance in the Netherlands studies. Wim, you correct me if this is not all right. In the German studies, only for the selected comorbidity, no significant difference in the Spanish study, and on the other side, significant differences in the Canadian study. So, to sum up the findings, psychiatric comorbidity is high in opiate dependence. We knew this beforehand. It has a risk for high dropout rates in addiction treatments, which is important because heroin-assisted treatment is only accessible in all these countries which have introduced it for treatment-resistant patients who had been in methadone maintenance before. Psychiatric comorbidity has potential for improvements in heroin-assisted treatment and in some studies superior to methadone maintenance treatment. And above all, psychiatric comorbidity is no contraindication for heroin-assisted treatment. Thank you for listening.